afternoon and good morning in some cases. Welcome to the second in the series of speakers that Orion Health is bringing to clients and potential clients across the world. My name is Andrea Tate, and I'm the Vice President of Client Value here at Orion Health. I'm very pleased to welcome Innovation Care Partners, who are a very successful accountable care organization out of Scottsdale, Arizona. A few housekeeping things before I introduce our speakers for today. If you can please keep yourself on mute and submit any of your questions through the chat function, we'll make sure that all of your questions are addressed at the end of the session. Without further ado, I'd like to introduce Farron Thompson, who is the Chief Operating Officer at Innovation Care Partners, and he'll be joined by Karen Vaneski, who is the Chief Clinical Officer at ICP, and they're going to talk today about the transition care management and how their accountable care organization has really successfully implemented transitions of care. So Farron and Karen, thank you very much.
Thanks, Andrea. It's a pleasure to be here. Point of interest for everybody, I'm originally from Sault Ste. Marie, and pretty much all of my family still live back in various parts of Ontario, from really far north in Ontario all the way down to southern Ontario, Huntsville, Toronto area. So, what I've been living in the US for a long time, and in healthcare here in Arizona. I think a lot of what we've been doing in the US around accountable care organizations, you'll hear probably some different terminology from us than what might be being used in all cases in Ontario with Ontario health teams, but I know for a fact there's a lot of similarities with what we've been doing here in our organization for the last 8 years. And I really hope that there's some nuggets of lessons learned or wisdom that we can impart to you all up there, because clearly I have a lot of family, a lot of vested interest in hoping that the next evolution of healthcare in Ontario goes well, and that there's continued improvement like we're all trying to do in the US and Canada. We're always trying to move the ball and make things better. So thank you for having me. Kara, if you can go to the next slide, please. I'm going to spend just a few slides orienting you to who we are with our organization and a little brief history. And then I'm going to turn it over to Karen, who's going to spend most of the time talking about our care management program. So this is where the terminology starts getting interesting. In particular, we are what's called a clinical integration network, and also an accountable care organization in the United States. What makes us an accountable care organization, and you've probably heard that term mostly from the United States, is that we're a participant in the federal Medicare Shared Savings Program. And that means we have a contract with the federal government for Medicare fee-for-service patient population. And then what makes us a clinical integration network is we have lots of other payer plans and patient populations that we manage, and how we manage them, it's all the same. But technically speaking, we have commercial payer plans, we have Medicaid plans, and we have Medicare Advantage, and we even have what's called, I'm sure you've heard Obamacare. We have an Obamacare plan that we are responsible for as well. We're wholly owned by a hospital system here, headquartered in Scottsdale. That system is called Orion Health. But we really kind of run ourselves fairly independently of that organization. So we have a great relationship with them, but I wouldn't say we're completely under the thumb of them. We're not run like a project or a department out of the hospital. We really run ourselves independently, like a separate business, a separate going concern. We have our own board. our own governance structure, et cetera. So that's a little bit about how we're structured and who we are. Next slide, please. This is our strategic framework. Some small words on here, but they mean big things. So our mission is that we really are after providing coordinated, high-value, evidence-based care to improve the health and well-being of the patients and families we serve. And our vision is that we're going to be the leader in innovative healthcare delivery with exceptionally high quality, balanced against cost, and be the preeminent partner of choice for our aligned physicians and payers. So that speaks a lot to, you know, how we behave and our strategy and the things that we do on a routine basis to run our organization, and how we've built and run the organization over the last 8 years. So a lot of what you'll hear today is all driven from that high-level strategy. Next slide, please. Some quick facts about us. We started back in 2012. We had a different name then. We actually started off as a 50-50 joint venture between what was then a 3-hospital system and the physicians that made up our partnership at the time. We changed our name in 2016, became wholly owned by the hospital system and then we started managing a second ACO then as well. You can see some of our statistics in terms of how big we are. Pretty much about 2,000 physicians. The vast majority of them are private practice, independent, across a great variety of all types of specialties, including primary care. And we're running about a $35 million US budget. I don't know what the conversion factor is these days, but a little bit more in Canadian dollars. And just a little bit to kind of toot our horn a bit and kind of demonstrate to you that, you know, we do have a reason that we can do webinars like this. You can read a lot of these statistics, but, you know, back in 2017, for example, there was 472 ACOs in the United States. We finished third in terms of how much we saved the federal government as a percentage of baseline costs, almost 17%, and sixth that year in terms of how many dollars we actually saved them, which was $46 million. That was our best year of performance. We've had a really good track record overall, but that was certainly our best year, and we've done really well trying to, you know, consistently improve and consistently manage our populations. Next slide, please. A little bit more about our physician makeup, how many primary care physicians we have, you know, close to 300, or a little over 300, and then a lot of specialists. You'll run across some organizations like us where they say, you know, they're only primary care, and they'll kind of use referrals and hang that over specialist heads to improve the total spectrum of care with specialists. We've taken a different approach, and it's kind of a big tent. We invite all physicians to join us. And you also hear other organizations like us say that you can't be successful unless all the physicians are employed by the health system or by the organization. And only you can see about 400 of our physicians are employed by the health system, yet we've been able to be very successful. Next slide. This is just a map, high-level geography of the Phoenix metropolitan area, where there's about a little over 6 million people that live here. And you can see that our hospitals that are part of our network with Orion Health are somewhat north and central located in what we call the Phoenix Valley. But our physician practices, both primary care and specialists, are really spread out and have pretty good geographic coverage around our metropolitan area now. Next slide. And just kind of before I getting to wrapping up here and passing it on to Karen, we've grown to cover about 175,000 covered lives, and you can see the makeup of those with what percentage are through the Medicare Shared Savings Program, how many others are Medicare and commercial. And then we actually have a Medicaid portion now, which is probably about 20% of our lives as well. So a little bit deeper distribution. Next slide. When we're speaking to folks, we either talk about all 5 of what has made us successful and really what we focus on a routine basis, or we talk about one of these areas pretty specifically. And when we were planning this with Orion, we thought really, let's dive a little bit deeper into our care management program, which includes 2 aspects. Care coordination, which is more ambulatory, as you'll learn from Karen, and then our transitional care management program, which is really picking up patients in the hospital when they're being discharged and managing their care for 30 or 90 days post-discharge. So with that, I'd like to introduce Karen Vanaski, who leads that program for us and has done so for many years, I think probably 6 or 7 years now. She's our Chief Clinical Officer and will lead us through the rest of the way here. Karen?
Thanks, Farron. I appreciate the intro and being able to share with you our successful care management model. And I'm just going to move the slide ahead. One more. Thanks. This is our care management model. You can tell that we have a central care management department, and we always like to say our model kind of hugs that patient through the continuum of care. We have a team of transitional nurses and social workers in the hospital, and we have 5 hospitals that they meet and greet our patients in, and I'll tell you more about their key role. And then as the patient leaves the hospital, our model moves with them. And if they go to the post-acute setting, a nursing home, acute rehab, etc., they will have a team that picks them up and follows them there so that the plan of care remains intact until they're home and back to their primary care doctor, because that's our key person to keep communicating with throughout this model. And you can see we have our care coordinators embedded in our primary care practices and caring for those moderate to high risk patients in those practices. We also have a central team here in the office that helps with practices that are new or maybe don't have space for a care coordinator. We do have a central team that works with that population that we can't get a care coordinator into the office. The other important piece of this model is our payer relationships. Farron showed you a slide, and we have multiple payers that we have contracts with. And it is important for us to have a relationship with those payers, to understand their services, their programs. Each week with those payers, we have a 30-minute huddle, and we talk to their clinical team about patients within the continuum that we're working with, that we feel we may need their support with. And then the other piece is that we get education from the payer on their programs. Some of them have meals that they can give patients after discharge, etc. I'll go to the next page. And this goes into a little bit more detail on the 2 components. Even though they work very closely together, these are the 2 components of the program. The transitional team, and I would say their main focus is to keep the primary care doctor notified on what's happening with the patient, if the patient ends up in the ER or admitted, or maybe is leaving the hospital, that there's a clear communication between the healthcare team in the hospital and the primary care in the office. And then our comprehensive care coordination program is an intensive outpatient care program And we train our care coordinators, who are usually, I would say most of them have a medical assistant level background. So they're very used to or accustomed to working in the practices. That's a very familiar environment with them. But we do have others that have other degrees in either psychology or healthcare leadership or administration. So we have other degrees also. But we spend a lot of time training them on this intensive outpatient care program, and I'll get into that in more detail in just a minute. So let's do a deep dive into this comprehensive care coordination program. I'm going to go to the next slide. So they're embedded in the practices, and you can go to the next slide and you can see that we have multiple practices over the Maricopa County area. The red dots on this particular map show where we have a care coordinator embedded in the primary care practice. So we have a large footprint. And then the blue ones are either there's not anybody embedded there. There may be a new provider that have entered, or they may be a very small practice. A lot of them have very small practices and have no space. So that's where we cover them with the central team. Next slide. So looking at, this is probably one of the more important aspects, is this comprehensive care coordination program, because we've looked at many over the years. We actually participated in 2014 with a CMMI grant through Medicare here, with about 26 other ACOs, IPAs, to look at this model and test it. And it's called the Intensive Outpatient Care Model. And we found through that Medicare study that you can get really very good results by keeping the patient engaged and involved in their healthcare, and really removing barriers to what they're finding in their life to being focused on their healthcare. It might be transportation or other complex issues. And so we work with the medically complex and deliver a personalized care plan using this model. So I'm going to go to the next slide. So this is the core function inside the model. So it's primary care based, and we use a predictive analytic software to identify moderate to high risk patients that may have that the health plan has on board. We use claims data, and each quarter we run a new list of moderate to high risk patients. But as many of you know, in a physician practice, the care coordinator can probably ask the primary care doctor, who do you think is going to be admitted to the hospital or go to the ED this week? And they know their patients. But this tool helps capture some that we may not have identified. And so we can enroll them. We train the care coordinators over a two-month to 6-month process. We train them in behavioral modification interviewing. We train them how to create a super visit where we gather many data points on the patient, maybe transportation needs, where they live, what's their social environment, so that we can know where we can best help them. We do medication management, and the PCP will look over what's in the home, medications they're taking like vitamins, things like that, as well as prescribed medicines. And what we always find in this area is that a patient may be prescribed a medicine, but we train our staff to ask them how they're actually taking the medicine, because many times they don't take it the same way the physician thinks they're taking it. They may say, no, I don't take that evening one. It kept me up all night. So we really train them to ask the right questions. And then we do 3 assessments, a quality of life assessment called the VR12. We use a tool called the PAM, Patient Activation Measure, to determine how intensely the patient is engaged in their own healthcare. And it will measure them through a 1 to 4 level, 4 being highly engaged and involved in their health needs, and 1 being not so engaged. And then we do a depression screening. The care coordinators work with a patient on a shared action plan, on what their goals are and what their needs are, and help them determine what's achievable and do a very patient-centric plan. And they do a really high-level face-to-face contact with patients and providers. We do home visits. We haven't since we've been involved with the COVID outbreak, but we do home visits as a part of this so we can assess the home environment. Next slide. This is just some tools we use. If the PCP is concerned about medication compliance, or maybe the patient has gone to the ED due to some falls, or they may be concerned that there's no family around and they're a frail elderly patient, they might be isolated, and many other concerns. We see a lot of, if they've had frequent falls, sometimes when we do the home visit, we can see they might have a hoarding issue and there's too much clutter in the home, or just signs that the caregiver is fatiguing and needs some support. So we have all these many levels. Obviously, if their PAM level, their activation level is low, we'll do a home visit to see if there's other barriers we're not catching that might be making them more high risk. And then we have tools for the care coordinator. We have a home safety checklist, a fall risk assessment. Each week we train the care coordinators we bring in a new community resource. We truly believe that the care coordinators are only as strong as their toolbox. So the more community resources they know, then the more they'll be able to pull one out of their box and use it with a family or a patient that needs that particular tool. So we do an hour a week on just a new community resource that's available. And then we do safety training, and then the supervisors do oversight. Before they can go into the home, they do have to have a state fingerprint clearance. So we do have safety involved in that too. Next slide. One thing that makes the care coordinator and transitional nurses in the hospital and the nursing homes very functional is our health information exchange. We call that innovation exchange. And this is a one-stop look at their patient's trending in healthcare. If they're started to have more ED visits, they can see labs, home health information. If they've been in the hospital in Maricopa, they can see information from payers, from just a plethora. And all they have to do is go in and click on the patient name. I think this is probably what gives our clinical team its strength, because they have a lot of information at their fingertips to make good decisions or to catch escalating issues quite quickly. All the hospital data goes into this. We have a state HIE, and that data goes into this. It's linked with some of our HIPAA compliant texting system. And we'll talk about this again in a little later. Next slide. You can see our HIE is a very easy login process. It's got robust health information in it that is just a one-stop check. It's very easy to use for our clinical staff, which is a very big gift. We always like to have easy technology. And there's so many longitudinal patient records. So it'll even trend out how many office visits, how many ED visits, and you can start to see if a patient is getting in trouble or maybe has a new diagnosis, those kind of things. It's a very supportive tool. And I'm going to speak a little later because one piece we really like in our HIE is the ability to develop a relationship in there with our patients and have it notify us. So I'll talk about that in a few minutes. So I'll go to the next slide. The care coordination program, really what we want out of this program is improved patient health. So what we do is we do those assessments on quality of life and depression and how engaged they are and in their own healthcare. And then we repeat those 3 assessments every 6 months. And this is just a quick look at how we've been able to show improvement with our patients. The percentage of patients with severe depression has lowered. We can get them more engaged in the community, have volunteers visit them, many other interventions that we use. And the impact of their physical chronic illnesses as they decline, we don't want that to impact their mental quality of life. And you can see we actually like this number to be higher, that we are keeping them more active. We have the right equipment with them so that they are more active and physically engaged, even though many of them are chronic illnesses and that they're dealing with some big impact, but we're able to keep them moving. And then lastly, the patients are highly engaged in their own care, and we've been able to move people with their activation levels from a level 1 up to a level 1 and 2 up to a 3 and 4. And that's a 16% increase. That's not an easy task to get people more engaged and move that mark, but studies show that if you can move that mark up, it does lower their utilization of healthcare services, that they're more in control. So they have less ED visits, things like that. So we're quite proud that we're able to get our population more engaged in their own care. This didn't come easy, and on the next slide, I'm going to tell you a little bit about some growing pains on this. So some of our lessons learned on this care coordination program is that you have to have your clinical team talking together. A traditional EMR is not going to solve your problems. You really need a software program that follows the pathway of your model and enables documentation that your care team can see. And that's probably the biggest piece. And then that you have a model to follow. I have seen a lot of different care management programs started up nationally, and they fail because they don't really have a model to follow. And if you've been in a physician practice, care coordinators or medical assistants or any staff can get pulled in so many different directions. But what we set out to do is, this is the model, this is their core work, and we taught each practice what that model entailed, how many calls they give the patient a month. There are certain guardrails for the model. So I think having a defined work process is very critical. And I think that really helped our program is to institute the IOCP model. The next point is to keep the care coordinators out of office work. A lot of times they'll be grabbed to do other things. The nice thing is there are employees, although we're embedding them, the offices quickly learn that the care coordinators doing their IOCP model are really taking a lot of work off of the office staff who would get calls from those high-risk patients multiple times. And so it's really been a help on them. Educate those community resources weekly is so important. It's important to hire the right person into this role. They have to be a people person. Innovation Care Partners uses a tool called Predictive Index that helps us identify the right people that can really be empathetic and develop a trusting relationship. One of our lessons learned was to develop a chat group or a place where all of your care coordinators can talk and say, I've got this complex issue. Has anybody dealt with that before? Do you have a resource for it? That has been really good. And then measure your program results as we do. So the next part of the program I want to talk to you about on the next slide is our transitional team. And our TCM team is so important. So I'm going to have you move to the next slide. They're really like the communicator when a patient is in the acute care setting or post-acute. And so that's when most of the healthcare people are all looking at the patient. They're the central communicator. On the next slide, you can see that we have a team of transitional team in the hospital. We also found it was very important to put them in the emergency department. It seems to be a place where we can determine and work with the emergency department doctors about moving them back out. If they don't need acute care, we can find them another level of care that's more appropriate. And then in the nursing homes, our post-acute team. The next slide talks to you about how this role was really created to keep the primary care doctor up to date on what's happening with the movement of their patients and where they are, and this clear communication to the primary care physician about the treatment plan that's going on and being developed by the hospital physicians. Many times the transitional team can give them information back about what's been going on in the primary care doctor, who the specialists have been involved in that patient, and even with the care coordinator. The care coordinator may have a lot of information about the family. They may have done a home visit that they can give the transitional care management team to give to the hospital staff. So a lot of communication goes on here along that continuum. Our next slide is just really a flow grid. We did a lot of work flowing out where are the key focus areas for patients coming through the system. We need to identify our ICP patients. We need to move them through the system. We need to make sure they continue to flow. So I like the flow grids. I think they're very helpful for the staff to identify key pieces of where their work is important, especially on the acute side, determining what is the most appropriate next site of care. We have tools we give them for next site of care assessments. and then moving them through to the post-acute. We've done a lot of work over the last year in the post-acute areas, so I will share with you a little bit of that towards the end of this. So, and probably their main goal is to prevent that smooth transition and to prevent readmissions. The next slide, you're gonna laugh because it's another flow grid. Here we go. Just shows the same acute next site of care, how that discussion goes, how do we support that continuity of care, how do we touch base with the different people. One thing we did teach our team is that it really is not a handoff or a transfer or anything. It is a warm handover of care, that this keeps the patient safe. So we changed the terminology to warm handover, that we're just gently giving you the information and making sure that patient is safe. And we get them to our preferred provider network. So we have relationships with the next site of care outside of the acute, and I will talk to you a little bit about our preferred provider network in a minute. The next slide talks about all the different services the acute or care coordinator can pull in to wrap around a patient as he's moving through the continuum, whether it be the care coordinator going out to the home or enrolling him in the program, the IOCP program, versus mobile physicians going out, or home health, or we have mobile urgent cares that can go out and do more services in the home. And then we have mobile telehealth that can take technicians out to the home and actually do very high-tech exams, including ultrasounds and video conferencing with a physician. So there's multiple services, and we help the transitional team know which ones are best. The next slide, I remember when we talked a little bit about our HIE and how that one-stop shop is so important for this clinical team to get the best outcomes for the patient. So we have patient notifications and smart cards that come to our phone. So Tiger Connect is our HIPAA compliant texting system, is integrated with our Orion HIE, or the Innovation Exchange. And the primary care or the care coordinator can pick a patient, tell the system they have a relationship with that patient and they want to be notified, and they can tell the system what do they want to be notified. They can be admissions, inpatient admissions, ED visits. It can be maybe a lab test if they're following that. And this is how we get the text. This is just an example of how it comes to our phone. And I think the next slide even blows it up a little bit. This is an ED patient notification or an admit. So the team in the hospital can go down to the emergency room and say, so-and-so is I just got a ping that so-and-so is in the emergency room. They can go down and begin to work with that patient also and help avoid the admission if at all possible. Powerful, powerful notifications. At the next slide, I talked a little bit about our preferred provider network. So the nursing homes, the acute rehabs, the home health agencies, the hospices, we handpicked our network. We did a lot of analysis on these preferred providers, looking at clinical outcomes and quality of their service. We talked to our physician network about it, and we bring them in quarterly. We signed a contract with them, etc. And we have a relationship, a very tight relationship with our preferred provider network. We survey them. We go on site annually. On the next page, it kind of goes through our process. So we sign an agreement with the preferred provider. We tell them our expectations, the quality metrics. They use our technologies, such as our HIPAA compliant texting. Many of them have access to our HIE. We really find the main points of contact that we need to get the best outcomes for the patients. We share with them tools and resources because we want them to be successful. We do training with them. We bring them in to do a preferred provider fair, so all of our clinical team knows the services they have. Some of the home health have special CHF programs, so we want our team to know where these strengths are. So definitely the preferred provider fairs help everybody come together and see that. And then our care team has our preferred provider directory that they can give patients if they're trying to select a nursing home or a home health agency. They know that we've vetted them and work with them. And just to give you one more, the next slide has a great flow grid. I hope you can read. If nothing else, it's impressive the work that went into it. When a patient is in a SNF, this really gets into detail on what the post-acute transitional case managers look at. They look at the best evidence length of stay guidelines for that patient so that the nursing home already knows kind of what they have to get done on this continuity of care. What is their target estimated length of stay? How are they going to identify early monitoring and change of condition so that we don't have a readmission, that we can get the care in the nursing home quickly? How to prevent readmissions, how to use teach back guide for patients and families so they're independent when they leave. So these are just some of the work that goes on in redesigning the care out in the nursing homes. I think that's important. But when you put the whole care team work together, from the care coordinators to the transitional team, to the post-acute team, to the ED TCM, where we really see our impact is our readmission. That is a big focus for us. And on the next slide, you can see our trending. So any ICP patient who has fallen within our program, we trend their readmission rates, and we have been successful to keep them down for what I consider mostly a Medicare population. When you can wrap services, appropriate services around your patient population, you can get the outcomes you need to have. And then the last slide is, or almost the last slide, is we do daily reviews of readmissions. We trend and target what our interventions are, what's working. We work on that post-acute redesign, and we use our mobile partners to help keep those readmissions down. Lessons learned from the transitional team. We started out on the next slide that we had only RNs in the hospital and only social workers in the post-acute nursing homes. We found that the acute TCMs needed some social work. So we have a mix now, and that was a great added value, is to help that transitional team be stronger with some social work in the hospital. But usually by then the medical needs are slowed down and the social works in the post-acute do very well. The other piece is that we didn't own the discharge process. So we would meet and greet our patients, but the inpatient team developed the discharge plan. And we found many times they didn't get to our preferred provider network. They didn't get the services we thought they might need because we knew the home setting. And so we have just started to take over that discharge planning. I think that's going to be a strong game changer because we can get them to our preferred provider network. So that's a huge piece. And then communication in one EMR, we talked about that. It helps decrease the readmissions, and just giving them the tools and the guides and the services they need is huge. Continuous training. In fact, this year we're going to start a simulation lab so we can bring in our clinical team and do case scenarios, and we may dress Farron up as a patient and he can give the team a run for their money as far as their his discharge plan. So those are some of the fun things we do to keep our program strong. I'll pause there and see if there are questions.
So Kara, have we received any questions in the chat?
Not yet, but if anyone has any and they'd like to place them into the chat, we can answer them now, or you're more than welcome to send them along to me and we'll do our best to get them answered.
Sure. In the meantime, I have one, and I think this is probably for both Karen and Farron. How do you approach measuring the efficacy of the things you do? So what does that look like? What do you measure? How do you measure it? And then how do you decide what changes to make based on that measurement?
Go ahead, Karen. You're closer to it.
I think measuring the program is a continuous thing. We are always continually looking at data and outcomes. When we see our readmissions go up, we definitely know we've got to hone in on why that is happening. Is it a different service, maybe a new provider that is having struggles, or is it a new service that we have in place? So I think we measure it through our tools that we have and look at those outcomes, especially the assessment tools. If we see an increasing depression levels in our population, that's an issue, and we need to hone in on that.
Yeah, there's a lot of, just to add on to that, there's lots of data and lots of analytics that we have, and we could spend a whole webinar or more talking about that. There's kind of operational metrics and measures that, like somewhat Karen was talking about. Ultimately, our performance is measured by all of our payer contracts, and there are really two big common threads across that. One is what's the total cost of care that we have for our population, and the other are various quality metrics, mostly geared around HEDIS metrics. Those are at a higher level of measures that we have to measure ourselves against and our peers measure us against. But then there's lots of other operational metrics that, if you're not doing those things well, then your overall metrics are not going to be good.
Thank you. That's helpful. Okay, if we have no further questions, Kara, I believe that we were going to make this session available to some who couldn't join.
That's correct.
And so for anybody who wants to share this with colleagues or with other people that you think might be interested in it, we're happy to make this available to you electronically, and you can share it with others. So on behalf of Orion Health, for both Karen and Farron, thank you so much for taking time out of what I know are very busy times for you. I appreciate that both of you are right in the thick of managing as health service providers a global pandemic, and we really do appreciate you taking the time to help us better understand your success.
Thanks.
Thank you.
We're happy to do it. We're all in the healthcare improvement journey one way or another at different stages, and hopefully we'll all be successful on that journey. Thanks, everybody.
Thank you. Bye.